welcome to our lovely Saturday night NCE session. Welcome to World Changers, and this is Pam Turner. So, as we get started looking at the DSM, the first thing I want to talk about was just in general the importance of diagnosing. Really, it's okay to second guess a diagnosis, but in general, you're just going to look at that. The changes to the DSM do include, though, the taking away of the 5 axes. We no longer have those anymore. We used to have access to my personality disorders, and that was great because we could always have a place to put those. Because remember, personality disorders, they don't come for treatment, right? They don't have a problem. That is, they're ego syntonic, in sync with their ego. Okay, so then the who does, which I love saying, who does, is that has replaced the GAF. So if you see anything on the test about a medical problem, that would still be on the who does. Okay, so the GAF used to be your like global functioning level, right? You gave a score between 1 and 100. We've taken that away, but it's called the World Health Organization Diagnostic Assessment something. Okay, it's called the who does, just like saying it. So other than that, that's pretty much the major changes. Okay, dokie. I want to put a copy in this box before we go. Okay. So then, when it comes to depression, in order to have depression, I have to have 2 weeks of can't get out of bed, don't want to bathe, oversleeping, undersleeping, but for 2 consistent weeks where I have more the bad days are more than the good days. Okay, so really just 2 weeks. Sometimes I'm looking at some suicidality. Sometimes I'm looking at just a depression hit, just a depression hit. We do know that that is an issue of having a serotonin imbalance, right? So our Zolofts, our Prozacs, all of those things are SSRIs, where they really look at adjusting the amount of serotonin or the way we take it in our body. Okay, so when I think of depression, my first thing I think of are my SSRIs. So that's going to be my Prozac, my Wellbutrin. If you look up in the box earlier, there is a medication list up there that I put in. So you might want to go up and look at that. So we have 3 schools, of course, when it comes to our depressants. We will see our the first one, well, the old school ones, right? We've had those forever. Tricyclids. One of those might be a trazodone. So trazodone is just an old school antidepressant. We still use it now. Um, um, they use it in the hospital with old people sometimes because of some of the possible side effects. The other category, of course, is my MAOIs. My MAOIs, those are the ones those are the second class of my antidepressants. With those, though, you cannot have anything with tyramine. Like, what? What's tyramine? Anything with aged cheeses. Okay, so that's what we're looking for, is making sure we don't have anything with tyramine. And then, of course, my newer school ones are yes, we do prescribe trazodone for sleep. We sure do. It's a very old school um, SSRI. Okay, so when it comes to mine, we talked about before, my depressive disorder, my major depression, that's going to give me at least 2 full weeks, right? Okay, so then my PDD, my persistent disorder, that used to be called dysthymia. Okay, so that is now my persistent depressive disorder, right? So persistent means I have this low-lying, all the ways depression that just will not go away. I like this picture. Someone who's got PDD, their life is like they're always constantly trying to go up that hill. Okay, so the diagnostic clue is in adults.
Sorry, are you sharing a screen? Because I can see you, but I don't see anything you're sharing.
Well, let me make sure I'm sharing. Thank you. Is that better? Yes, no, maybe.
Thank you. Thank you. Yes.
Yes.
Okay. So and thank you for saying something. Okay. So my PDD, again, that's my persistent depressive disorder. Okay. So you can see that it's like always this way. Oh my gosh. It's just always this way. Okay. Life is hard and it's always going to be hard, Persistent depressive disorder really has been around. In order to be diagnosed with it, you have to have those symptoms for at least 2 years in adults and 1 year in children. Okay, so persistent depressive disorder. I'm still going to use one of my lovely my SSRIs, right? My serotonins. Copy that image and put it in there. Okay. So my clinical depression, again, those 2 weeks. So changing your sleeping patterns, frequent thoughts of suicide, sadness, all those good things. So then with my persistent depressive, loss of interest in your daily activities, feeling down, hopelessness. But the key is the time. The time happens, it takes a long time. It's 1 year for children for my persistent depressive disorder and 2 years for adults. Okay? So when you're looking at those questions, you're looking at time frames. Okay? Hopeless, gloomy behavior, appetite changes, all of those things. So that's what I'm looking for at my persistent depressive disorder. I'm still going to treat it the same way. So the treatment for any mood disorder, is CBT and medication. Don't care what you do in your private practice. I'm going to tell you what the test answer is: CBT and medication. Okay. So I don't care if you don't want to tell people about medication, but for the test, cognitive behavior therapy, changing those stinking thinking patterns, right? That's Aaron Beck. So changing those patterns and doing some cognitive restructuring along with the medications. Okay. So then when it comes to then my bipolar disorder, I have bipolar 1 and I have bipolar 2, but I'm going to come back to those. So that postpartum depression, that's in there still. Okay. If a question talks about a mother coming in and it's been like a few weeks since she's had the baby and she's feeling extremely sad, one of the first questions you want to ask is find out the time frame, right? What you want to know is how long has this been going on? Okay. If you see a question, you might see a question about a mother who's been diagnosed with persistent depressive disorder, and she is sharing thoughts of hurting her baby. That's one that you would call in. Okay, so you would call that one in. So SAD, that is seasonal affective disorder. It does not have to be just for the winter. If you haven't had me before, I do have seasonal affective disorder. If you can see my very bright light. Okay, so as the seasons change, I'm from South Florida and I miss the sun in general, and I feel blah, like I just can't. And when the time changes and I've got I used to go to work at dark, now I work at home, but I just can't do it. But it is not just for the winter. Some people can have it in the summer, people can have it at Christmas time. So it's during that season they feel extremely depressed. Okay. That's SAD, seasonal affective disorder. My PMDD, this is probably the broadest diagnostic criteria that I've seen. I think the people who did the DSM were afraid to say anything of what it might and may not be. So it any week other than the week that you're on your period. So any other week it can be diagnosed. So it can be diagnosed a week before, 2 weeks before, a week after, any time except for the week that you're on your period. And you'll find that it really is, the criteria is so small. Okay. So then fatigue, mood disorder, anxiety, mood swings, all that good stuff. But again, you're going to see in the question that it's going to be around her menstruation, menses, any of those things. That's the words you're looking for to know that that's it. Situational depression. So that is sometimes what we call, some of the grieving. So now, do you know when we decide it's more than grieving? When does it change from normal grief to then it becomes a concern?
I think grief is on and off. You can have moments of happiness when you're grieving, and then you can return to grieving. But when you're depressed, you're not gonna have or is it is it a time thing too?
So that's the question then. So when does grief become pathological? Okay, so what we're looking for, usually after 30 days, So if I see a
Is it
woman,
when
though, go ahead.
is it when you have hopelessness?
Well, the diagnosis to grief versus major depression is, I mean, the question will tell you that it's been, the mother died, the dog died, the cat died. So you'll see that. But if it's been longer than 30 days and they still can't get out of bed, then it's going to become major depression. Okay, so grieving is normal. We don't want to pathologicalize it, make it sound like you're crazy. But what we're looking for is after 30 days, if you still can't function, you still can't go to work. It doesn't mean you're not sad. It means you cannot function. And you'll see, she can't go to work. She can't. She hasn't eaten. She hasn't done anything, and it's been over a month. Then we're concerned. Okay. I'm gonna mute. Should we just listen to our conversation the whole time, or should I mute her?
Mute
her. Fine. No, just listen to our conversation. Okay. Okay. So again, my SSRIs are what I'm using for my depression. Okay. So then when my depression lifts and I have this huge lift of bipolar, that it goes high, then I've got some bipolar. If the question in general just says bipolar, it really just is bipolar. Okay, what I'm looking for though, if it's going to ask me to differential diagnose between bipolar 1 and bipolar 2, then I'm really going to have to look at doing a differential diagnosis. So what I know is a bipolar 1 is my serious one, right? That is the one that you think you're the most amazing thing ever. Most often you're going to end up either in prison or hospitalized. Okay? So I know that no one has ever seen this show, but do you recall Shameless? The really messed up family that was on. I think it was on like Showtime or Netflix, maybe. It's a really great example of bipolar. The the mother would kind of come and go out of their life. She was married to a woman at one point, married to a man at one point. She came home and she decided she was going to redecorate the kitchen. So, she's like tearing holes in the walls and doing all these things, taking the cabinets out. And then, you know what? She crashes and she stays in bed for 3 or 4 days. Okay. And then, yes, bipolar 1 is the big one. Okay. Bipolar 1 is the one. And if you're not in the field, you don't even know there's a bipolar 2. And if the question just says bipolar, it's a bipolar 1. In that show also, it does show how her son then was also bipolar. So we definitely know there's a genetic piece to that one as well. So the definition for a bipolar, a full-blown manic episode, is at least 5 days, of not sleep. You are, off the chain, spending money that you don't have, sleeping with people that you would normally sleep with. In group one time, I was doing a parenting group, and I had a mother that said she was medicated. I don't know, but I could tell when she was in her mood, her high mood, because that hypersexuality is part of it. And she would come in, and she'd wear like a white T-shirt without the bra, and come in and just sit down, and her legs would be open. And like next week, like she'd be totally different. So that hypersexuality again, you feel like you're on cloud 9. So the problem with that, of course, is the higher the high, then we've got to crash at some point. Our body needs sleep at some point, and when you do crash, you crash hard. That manic episode really can last for like 3 months, though. I mean, it really can be way up there. Okay, so then when I'm looking at my bipolar 1, remember my treatment of choice is lithium. Okay, in the real world that is changed. We are now using more of the Depakote and Tegretol. Okay, but lithium is still the drug of choice most often for the answer. It does have a toxicity level. It's the same lithium that's in lithium batteries. So we really, that kind of can make us sick after a while. So bipolar 1, bipolar 2 is still going to be lithium. So my hypomania, hypo in general just means less. Hyper means more, hypo means less. So if I'm going to have a hypomanic episode, then it's going to be less. You might not even notice a hypomanic episode. You know what? Wow, have you noticed like every month Pam is in a really good mood? Kanye West. I can't diagnose. Sorry. No idea. No idea. um, I have known people in my family to be bipolar. Didn't know it at the time, and I'd sent my children to stay with a relative. And they said, "Mom, it's 3 o'clock in the morning, and she's up like moving furniture and doing stuff." I'm like, "What do you mean?" And she had not been asleep for a couple of days. So I don't. I'm sorry. I don't know. I don't know enough popular TV. Sorry. Um, but my hypomania, again, you might not notice. So the key with hypo one and bipolar 1 and 2, my bipolar 1, I do have to have that depressive episode. So I've gone down for like 5 days. Okay, I'm sorry, 2 weeks, that depressive episode. The question will say, then they put her on. She comes in with suicidal thoughts. She's extremely depressed. She comes in, they put her on medication, and she begins to rise. She can't sleep. She's restless. She's talking too much. And even after they've taken her off the medication, so she's bipolar, not major depression. With bipolar 1, I have the cycles. Okay. With bipolar 2, I don't have to have the cycles. I just have to have one episode, just one depressive episode to qualify for the hypomania for 2. If you see the green is our average disorder, right? So that kind of sees that all of us have good days and bad. Like, yay, it's payday, it's Friday, boo, it's Monday. You know, our moods go, but they don't swing that much. If they swing quite often, major ups and major downs for over 2 years, then that gets my cyclothymia. Okay, so cyclothymia is the major up, major down for at least 2 full years. Okay, so we don't have a cyclothymia for kids. So dysthymia, which is now a persistent depressive disorder, right? So we do have it for kids, but not for cyclothymia. And I'm going to treat all of those with my lovely lithium, right? Okay. So schizophrenia and schizophreniform and all of those others seem to always come up as well. So schizophrenia is at least 6 full months of having both hallucinations as well as delusions. Okay, so hallucinations, I can have all 5 of my senses can hallucinate. Okay, so what I'm looking for is, it's going to be big. Okay, all 5 senses. I can have auditory, I can hear things, right, that other people don't hear and see. I can smell things that other people don't hear. Those are my gustatory. I'm sorry, my gustatory is my taste. Olfactory is my smell. Visual things that I see, and tactile, I can feel things crawling on me. Okay, those are so all 5 of my senses can have hallucinations. Most often, I'll hear like, "Can't you taste the poison? There's poison in my food. They're trying to poison me. I can taste it." Okay, when it comes to deciding between dissociation and hallucinations, I usually ask the client, is the voice coming from inside your head or outside your head? If it's outside your head, it's a hallucination. Okay. So schizophrenia to me is one of the saddest diseases because we don't really know what triggers it. We do know that the most common ages are between 17 and 45. So most often what you'll get is someone who was, doing great in school and having a wonderful time, and they're in college their first or second year, and suddenly mom gets a call because little Bobby Joe is like dancing naked in the fountains because she sees fire breathing dragons, right? So really, really scary, and we don't know what caused it. We do know there's a genetic piece, but there's a genetic piece with lots of other things, and not everyone gets schizophrenia. But the most common times are those late teens, early 20s. If you have your first psychotic break after 45, you're good. You probably won't have another one. So we know 17 to 45 is what we're looking for, but after 45, you are good. So acute. Somebody asked me a question there. I will. I'll get there. Thank you. Hold on to that. So acute The first one it starts off with is a brief psychotic disorder. That is 3 days to 30 days, right? That is my brief psychotic disorder. You know what? Pam comes in and she is, telling you that the little men are following her around, and don't you see the little men? That's my brief psychotic disorder. Okay, exactly the same as everything else. However, the difference is that it is. So I'm still having the hallucinations and the delusions. Those are still the same. What I'm trying to do though is we're really trying. We're hoping it goes away. We're really hoping that we do not have to diagnose this person with full-blown schizophrenia. So then, 3 days to 30 days is going to be my brief psychotic disorder. From 30 days to 60 days, it's a schizophrenia a form of schizophrenia. And then 6 months and so on, it is schizoaffective disorder. Okay? Again, I'm treating all of those with a good old antipsychotic. Give me some names of antipsychotics, guys. Sure, thanks. Haldol, Risperdal, Zyprexa. Any more? You're right. So, the problem with those lovely antipsychotics is I get that thing with my face. Thorazine, yes. Seroquel, yes. You get the bell. Thank you. Yes. Okay. So with my, I get tardive dyskinesia. Okay. So it's not only with my, it's most common in the face and most visible in the face. It happens in your arms and your legs, other places as well. Okay, but the tardive dyskinesia, those are involuntary facial movements. But remember, they are not muscular issues. It's a central nervous system disorder. Okay, so what it means, it's a way that the medication affects your brain, the way your thinking process. So that's tardive dyskinesia. So the Cogentin is the medication of choice to treat that, or it will actually go away when the person stops taking the medications. So when it comes to schizophrenia, those are the ones that we really have to, the questions you have to be careful about, because someone who is, as my mother would have said, not in their right mind, okay, my grandmother, not in their right mind, they have lost their right to self-determination. However, if they don't meet the criteria to they're going to kill themselves or kill someone else, I can't involuntarily hospitalize them. So you have to be really careful, because you can't leave them, but you can't make them go either. So you want to make sure, escort them to the closest emergency room, or see if they'll go to the clinic, get them to the clinic. But if you see a question and they're actively psychotic, I cannot hospitalize them because they're not in danger of themselves or someone else, but they've lost their right to make their own, that autonomy, they've lost that right. Okay. So then, again, central nervous system disorder, it does go away. So it doesn't have that way forever. I mentioned to you also that it has delusions. Okay. So delusions are the thoughts. I do suffer from some delusions. If you've watched any of my videos, I'm surprised that no one's come to pick me up yet. But I have erotomania, because I'm pretty sure that Barack Obama is in love with me. I'm sure he is. He's just waiting for Michelle to leave, and or him to get away, and he's going to come and live with me happily ever after. Don't laugh. It's true. So erotomania is a delusion that someone famous is in love with you. Okay. So yeah, he's in love with me. Okay. There's something else. Oh no, he's in love. How I know? I also have ideas of reference. So ideas of reference are when there's some truth to it, right? There's some truth to the piece. So many ideas of reference are clinical. I'm sorry, are spiritual or biblical. Like somebody sees a scripture and they take it out of context. So there's some truth in it, and then I expand on it. So when Barack's on TV, he lets me call him Barack because we got it like that. When he's on TV and he blinks his eyes like 3 or 4 times, that means he loves me. So that's how I know. So that is an ideal of reference. Yes, he does blink his eyes, but it's really when he touches his nose that he means he loves me. Exactly. So that is my idea of that's idea of reference. Okay? I am not delusional. It's true. Anyway, when someone is in a delusion, you don't convince them it's not true. So that might be a test question. So if I'm enjoying my Barack time, don't be telling me that's not true. Okay. So then, let's see here. Let me go back. Okay. So I think I got. Let me go back. So someone asked me about schizoaffective disorder. So schizoaffective disorder is when you have. There we go. So schizoaffective disorder is when I have a full blown bipolar disorder, okay? And I have been diagnosed with schizophrenia as well, okay? So full blown schizophrenia and full blown schizophrenia and then full blown bipolar. So when my moods go up, the more manic I get, the more bizarre my thoughts get, okay? And I have been practicing for 30 plus years, and I have never seen schizoaffective disorder outside of an institution. And if you have, please let me know. Most often, what we diagnose people with is bipolar 1 with psychotic features. Because on my high end, I can definitely have, I can have hallucinations, things also on my low end. So, but most often in the real world, we get a diagnosis of a bipolar 1 with psychotic features. Now, usually what I see is in the prisons, residential facilities, things like that. That's where I see a schizoaffective disorder. And most often, I have my own thoughts. There's no proof. I've not done research. But if someone is on a lithium as well as an antipsychotic, you know what? They're really doing like the Thorazine shuffle, right? Everything with schizophrenia slows your body down, slows your thinking down. You're very disorganized. You have clients schizoaffective. Can I ask you, were they diagnosed in an institution at some point? Because we really don't. I don't see that a lot in the real world. A lot of people. I have a couple people who work in prisons, and I see a lot of schizoaffective in prisons. I see it in mental institutions. Yeah, from the hospital, because I can heavy duty medicate you, and especially in prisons, right? If I've got someone that might be a little out of hand, and I give them that diagnosis, then we got them. Okay.
So how can you tell the difference between schizoaffective and bipolar 1 with the psychotic feature?
You really don't need to know. So if you want to text me later, I'll tell you. But for the test,
all right, no worries.
For the test, you don't need to know. Okay. And I'm not trying to keep information from you. There's just no need. That's something won't be on the test. Okay. So again, kind of my categories here. So I talked about my brief psychotic disorder. That's first. Schizophrenia form. That's the second one, and then becomes full blown schizophrenia. Schizoaffective disorder then also is got to be at least 6 months, and I have to have the full blown symptoms of schizophrenia as well as bipolar, like I said. Okay. So our personality disorders, hold on to those. I'll come back and talk about those in just a minute. Catatonia. Have you seen that one? I know it's awful, but it's so cool. Like, yes. If you've ever worked in a psych hospital, it's like so cool. I'm amazed, and I do apologize. I am not trying to be offensive to anyone who has catatonia, please. But I'm amazed at the way the body, how the mind affects the body. That totally amazes me. So people with catatonic really kind of like will stay in a very bizarre position for like a long time, like, and it looks uncomfortable and things like that. Excuse me. But that's really just part of schizophrenia. So I'm just amazed at how the body works. Impatient, most definitely, most definitely. So very cool. Just it's cool the way the body works. That's what I want to say. Okay, let's see here. So I talked about my bizarre a friend. Okay. So then, again, the delusions I talked about. So sometimes they're very bizarre delusions, bizarre, like, someone's coming in and they've taken out my they implanted something in my arm and took out one of my veins, things like that. Let's see here. I'll give you this. Persecutory, someone's after me. Again, that's my referential. So that's something that's based in reference, a reference to some truth happening. Okay. So gesture, when he touches his nose. Okay. Any of that, I believe that he's talking toward me. Thought broadcasting, I believe that my thoughts are being broadcasted over the TV. Things like that. Erotomania, of course, that's what I have. I'm going to say I do. It has been said that your current president does have some grandiose delusions. Okay, so somatic also is some sleep disorders. You might see some of these on there also. Have you seen nihilistic anywhere? Nihilism? So you might see that. So nihilism just thinks that, the world no longer exists. Okay. And jealous, I've seen that one also, like someone who is, have some very bizarre thoughts. So your hallucinations again, gustatory, all of those. So we have negative and positive symptoms of schizophrenia. The negative symptoms are the things that you're missing. Okay. So what you don't have, you don't have an appropriate affect. Your affect is flat. You have limited speech. You have lack of pleasure. So those are the negative symptoms, the things you should have. The positive symptoms are the things that are added, and the things that are added, of course, are going to be like my hallucinations and my delusions. Okay, I'm going to put that in the chat box as well. Okay. When it comes to like conduct disorder and ODD, opposition defiant, what's the difference? What I'm looking for.
Is the one the precursor to the other, like oppositional defiant? Like, well, I don't remember the order, but the one happens when you're younger and then you transition to the.
No,
No?
you're talking about a personality disorder. We're going to go there in a minute, personality disorder. So yes. So the difference between ODD, opposition defiant disorder, and my conduct disorder is most often the amount of the intent behind it. And in the question, I'm always going to look at the if he's breaking the law. If they're breaking the law, if it's a kid who, and they have to be diagnosed by the time they're 13, then that's my conduct kid. No remorse. They're the ones who were like poking the animal's eyes out and, pulling the tail and things like that, right? Okay. So that's what I'm looking for when it comes to that situation. My ODD kids they do not follow rules. They are still going to throw a table. They're still kids who are not going to listen. All of those good things. However, they are the ones who are more likely to have some remorse. So that's what I'm looking for, is some remorse. Okay. Your kid that tried to jump out of the bus, are you sure he was? Oh, okay, so break the windows. I had a kid do that once, and she was just psychotic. She really thought she could fly until her medication kicked in. We just had to tell her that the other kids couldn't fly. We needed her to like stay on the bus. And she was, yeah. And she was really, yeah. So we do see childhood schizophrenia. Not a lot, thank goodness, but there is childhood schizophrenia as well. Okay. So you did mention though, you talked about let me close some windows here. So I briefly touched on some of those personality disorders. Okay, so ego-syntonic versus ego-dystonic. Ego-syntonic are things that are in sync with my ego. Okay, so if it's ego-syntonic, I am not coming for treatment because I don't mind. Exactly. Ego-syntonic is in sync with who I am. Okay, my personality disorders, it is in sync with who they are. They are not coming for treatment because they don't mind this. They've always been this way, and there's no need for them to change. Okay, that's my ego-syntonic. Okay, ego-dystonic, I always say, I don't like this. I'm coming for treatment because I don't like this. So all of my personality disorders are all ego-syntonic. Okay. I haven't seen them diagnosed. Childhood bipolar, we're going to talk, it's usually called the PMDD. It's the uh, disruptive mood disorder. So it's the bad kids in the grocery store that can't behave. I didn't say that as a non-judgmental clinical person. That disorder used to be called childhood bipolar. So those are the kids who have extreme reactions to their moods. Their moods are everywhere. Okay, and if I offended anyone, I do apologize. But yeah, so they're overly emotionally all the time. So you're looking at, crying excessively over things, personality disorders. And yes, but so there's not a childhood bipolar anymore. Okay. Yes, disruptive, what's it called? Disruptive mood. No, it's disruptive mood.
Disruptive mood dysregulation disorder.
Thank you, thank you. That's it. DMDD. I haven't seen that on the test. I've seen it in study guides, but no one has ever told me that was on the test. Anybody have seen that on the test? Yeah, I haven't seen it, so and I try to, and not that I've taken the test, but I try to harp on people the ones that you should see. Okay, so and also we used to teach these in clusters. I think we've taken that away as well. I don't think we ever see these in clusters anymore. But in general, my personality disorders are ingrained. They've been that way since they were a kid. Okay, gotcha. Okay. So they've been that way since they were a kid. So they're not coming for treatment because they don't have a problem. We don't diagnose them until they're 18, except for those lovely borderlines, right? They 16, 17, we diagnose them. Okay. If you're not sure what a borderline is like, all you have to do is if you've spent time with someone for more than like 20 or 30 minutes and you feel crazy, they're borderline. Okay. All good, all bad. They love you, love you, love you, hate you, hate you, hate you. When you have a client come in and she says, "Oh my gosh, I have seen 17 therapists before you, but you are the very best one ever." I can promise you, you are not. Sorry. She's seen 17 already. You are the one that's the best for this moment, but that's not going to last. So they're known for splitting, all good, all bad. There's nothing in between. Love you, love you, love you, hate you, hate you, hate you. Okay. So then, yeah, hold on. You're getting ahead of me now. Don't go there. I'm just talking about personality disorders, okay? So my personality disorders that are all egocentric. So paranoid, schizoid, and schizotypal. Again, they're not coming for therapy because they don't see a problem. My schizoids, those are the ones that you will never see, right? You probably have a neighbor who's schizoid, but he's never coming out. They're loving COVID, right? No need to leave the house ever. Okay. The schizotypals will talk to you, but you will be so sorry that they did. The borderlines are extremely challenging. The way to treat borderlines, and again, it might be. The way to treat borderlines is that's what dialectic behavior therapy is for. That's what that was invented for. And we also want to take that mood and make it ego alien or ego dystonic, foreign with their current mood. Okay, trying to make my picture bigger there. So my schizoid guy, he says, "Go away, Mr. Fish. He's by himself. He doesn't even want to talk to the fish." Schizotypals, they are again very, very strange. Okay, they'll talk to you, and you'll so wish they hadn't. They look very bizarre, very strange addressing, strange talking, just really strange. But they'll talk to you. They'll talk to you. My schizoids just want to stay away. Schizotypal, those are more like my schizophrenics, like a typical schizophrenia with their disorganization and their very bizarre speech sometimes, but no hallucinations and none of the delusions either. Okay. And again, they've always been this way. So if you look back at school and you remember the funny acting kids, the ones who wouldn't talk to you, those are the schizoids, but we don't diagnose them until they're 18. The other ones are my avoidant disorders. My avoidant disorders, they really, really do like people. They're just very much afraid of being judged. So my avoidant disorders, they will not talk to you. It's not you. They're just afraid of being judged. They're afraid, and you might see in the question something about they have. I'm trying to get rid of all of these. You might see in there that they have been ridiculed as a child, something like that, and they really are just not interested in trying again to put anything out there. Okay, so avoidance like people, but they're afraid of judgment. Okay, so again, my my borderlines, I'm going to diagnose. Sorry, we can diagnose those at 16. Everybody else we diagnose much, much later. I'm trying to clean up my window, guys. I've been teaching all day, and my computer will get really slow with the 5,000 windows open. Okay. So I always talk about the difference between OCD and OCD personality disorder. Anybody know the difference? Well, sure we do. OCD and OCPD. Okay, what I'm looking at, remember, my OCPD, they have been that way their whole life. They have no reason to change. They're not coming for therapy. They like who they are. Okay, and I am sure that I have tons of OCPD people in the room. You don't have to raise your hand, but if all of the things in your cabinets are lined up by alphabetical order and all facing the right way, or if your shirts are hanging up by shirt color or lens size and the shoes are in direct order, and you get very upset if things are not perfect, you are OCPD. Okay, so you've been that way. If I ask your mother, she would say, when she was a kid, all her dollies had to line up in the right color. So you've been that way your whole life. OCPD. OCPD people they're not coming for treatment. It doesn't bother them. Okay? It doesn't bother them whatsoever. My OCPD people aren't coming for treatment. Their symptoms don't get worse. Okay? And they want to be perfect. Their goal is to be perfect. If you see a question about which disorder be willing to turn their work in late, that's my OCPD people because it has to be perfect. Okay? OCD people now, COVID is killing them. OCD people have the obsessions, the thoughts over and over and over again. They're germs on my hands. Can't you see it? They're germs on my hands. So the constant thought pattern over and over and over again. Then the compulsion is to wash your hands. That is to relieve the obsessions in your head, right? Over and over and over again. So then my OCPD people are easily identified. Their hands are raw, or just like the skin is falling off, especially with COVID. They will come for treatment because the obsessions, the constant thoughts in their head get control, and they don't like it. They don't like it one little bit. So they're the ones that's an OCD is an anxiety disorder. Trichotillomania and excoriation, hair pulling, those are all actually anxiety disorders too. It's the obsessions, the thoughts in my head that I have to get rid of. So for an anxiety disorder, I'm going to use long-term. Zoloft is the one it's an SSRI. However, it is the SSRI that works best for anxiety. Okay. If you work with clients now, whether you diagnose or not, one of the ways to become very familiar with the medications, the diagnosis, is just read their charts. So if you're you're not where you actually get to diagnose yourself yet, read their charts. It'll become very familiar with you, and you really will be able to have no problem, answering some of these questions. Okay, my personality people, OCD, the blue, they believe again something awful is going to happen. If they don't wash their hands, then the bugs will crawl, blah blah blah, and they will die. I mean, it gets that bad for them. Okay, so OCPD is egosyntonic. It's in sync with who they are, and my OCD people, that is, they're the ones who are going to come for treatment. So that is ego dystonic or ego alien. It's foreign to their ego. There is also one more other disorder that is egosyntonic, and that is anorexia. My anorexics never think they're always too fat, right? They weigh 3 pounds and they've had 4 peas today, but they're too fat. My anorexics also. To know the difference between anorexic and a bulimic, what I'm looking for on the test is my bulimics are regular weight. My bulimics are not thin. So if the question says that person is of regular weight, okay, then I know that cannot be an anorexic disorder. Anorexia also, I'm looking for a lack of their period. Many times they've stopped their period. All those good things. Okay. I'm going to make sure, can everybody see my screen? I'm going to share some questions here. Move my screen back over. Okay. Yes, you can see my screen. Nod. Thumbs up. Let me know I'm not speaking to myself. Thank you very much. Thank you.
Yeah,
thank
we
you,
can
thank you.
see.
Thank you. Thank you. That's all I need to know. Thank you. Thank you. Okie dokie. So then, feel free to answer in the chat box. Okay. Okay. So then, number one, a therapist on an inpatient unit conducts an intake with a 42-year-old man. He was transported to the hospital by the police after an altercation in the park. Unable to provide a medical or social history, no memory of how he got to the hospital. The police check reveals that he's an executive of a large company in a city who was laid off a few days ago. At the end of his long weekend in the hospital, he recovers his memory. He's mostly diagnosed with what? Okay. My dissociative disorder, remember, used to be my DID used to be my personality disorder, right? MPD, multiple personality disorders, dissociative disorder. That's what that means. So if you ever saw the movie Precious, when things are awful bad happening to her body, like she's been raped and hurt, then she goes to the scene where she's dancing and she's beautiful, right? Okay, that's disassociation. So it is our mind's way of protecting the awful things that are happening to our body. So people will describe it as kind of, looking like dereal or being depersonalized. You can see it, but you don't feel it. Okay, so that's dissociative disorder. And this one has dissociative fugue. Fugue means a short period. It comes back. So that's A is the answer there. Okay. My factitious disorder and malingering, sometimes those get confused. My factitious disorder is when I'm faking it. Okay. I'm just faking it. I'm not really sure what I'm getting out of this, but I'm faking this disorder. Many times that's where you'll see that um, by proxy, Munchausen by proxy, right? I'm getting some attention. Malingering, though, is then I really want something out of it. So malingering in the question is really clear to see. An attorney comes to see you and swears that his client is depressed. The client cannot share with you any symptoms of depression. He's trying to get out of going to jail. Okay, so malingering is a lot easier to see. So if there's in the question nothing in there that says it's going on, then it's going to be my factitious. Also, then conversion disorder. Conversion disorder, sometimes it's called hysteria, blind hysteria. Conversion disorder is a central nervous system disorder. So what happens is something traumatic happens and I can't see. I can't walk, I can't hear. I mean, something traumatic happens and it really affects my brain in such a way that that part of the body I think doesn't work. Okay. So those people have always gone to the doctor before they see you. So if the question says refer to a doctor, that's not correct because they've gone before they've seen you. Okay. Acute stress disorder is what you get before it's post-traumatic stress. 3 days to 30 days is acute stress disorder. PTSD kicks in at the 31st day. Okay. Let's look at this one, my 13-year-old. Let's see what he might be. Okay. If I'm looking at my conduct, I'd be looking where he was breaking some laws, right? I don't see him breaking any laws, unfortunately. Okay. ADHD, he would be extremely inattentive. So I've got some ADD. Okay. I've got some conduct disorder. Okay. So I see some B and some D. So I will tell you, let's go back to the question to prove it. So if I'm looking at ADHD and he's predominantly inattentive, that'd be a kid who's like staring out the window, not paying attention, doodling on their paper, right? Okay. So the therapist experiences the boy as intelligent and highly verbal. That's the sign right there. Okay, but he avoids reading and writing. If I'm intelligent and highly verbal, then I've got a learning disorder. That's what I want to rule out first. Whenever you're seeing a question where the kid has high IQ points and he has low grades, he's very bright and his grades don't match, I need to rule out making sure then that he doesn't need he doesn't have a learning disability. In those cases, you would refer for a psychological evaluation. That's what a psychologist does is it goes in and we look at testing to determine whether or not he has a learning disability. Okay? So remember my neurodevelopmental disorders, those are the ones that develop when you're in utero most often. So autism, you're on the spectrum, that's a neurodevelopmental disorder. My neurocognitive disorders, those are the ones like my Alzheimer's, all those good things, those are the ones that develop as I get older. I lose cognitions. Okay. Oh, let's look at this one. Okay. It's a personality disorder. Let's figure out what this one is. I can share the copy of these questions, but I don't have the answer sheets not with it. So you're more than welcome to have the questions, but there's no answer sheet. Okay. So dependent personality disorder, bingo, bingo. Dependent personality disorder is really looking at the the fact that I can't make decisions all by myself. I think there is something wrong with me and I cannot make decisions. Okay. In your Reese's, remember that's pee on myself. I pee on myself. I have to be at least twice a week and at least 5 years old. We're not worried about about kids who have issues with peeing or pooping until they're actually 4. Okay, prior to that, we think it's normal developmental behavior. And I know that's not what your mom and them said, but for the test, we are not worried until they're 4. Okay, encopresis is poop, enuresis is pee. Okay, this one, my 11-year-old boy. That is not what the test says. And Freud would say, Freud would say that, remember that oral anal phallic? He would say that if you potty train them too soon, their little their little sphincter muscle will be tight. Okay, and by the 8, and they'll be like little tight their whole life because mama potty trained them too early. Okay, exactly. So this one, what is this one? What are we diagnosing this kid with? He's going to be conduct because he's had several incarcerations for selling drugs. That makes him conduct disorder. He has to be under the age of 18. He has to be diagnosed by the age of 15 and he's done something illegal. That's what makes it conduct disorder. Oppositional defiant disorder, again, those are the kids who are still pretty bad, okay, but they haven't broken the law. Now, untreated conduct disorder grows into what? B, my antisocials. Those people are not. They're not unsocial. They love people. They'll invite you over to dinner, like what was his name, Ted Bundy. He invited the girls to his car and come on in the car, and he smiled, right, and then he killed them, and then he blamed them. So my antisocials are my serial killers. That would be the term sociopath for a layperson. In our profession, we say antisocial, and most often because those antisocials have been it's personality disorder. They've been that way their whole life. So we know by interviewing the parents or usually the mother of the serial killers, right, that they've been this way since they were a kid. They were killing animals. Okay, they were doing things like that when they were a kid. No remorse whatsoever. Treatment for antisocial, if they are treated, many times is teaching them empathy to realize that other people feel pain. And the same with my conduct disorder kids. If you get my little kids that are conduct disorder, we teach them how to realize that the doggy hurts because they're not capable of understanding that somebody else has that pain. Okay, so please don't let anyone say that you're antisocial anymore unless it's true. Then don't tutor with me anymore if you're antisocial, okay? 'Cause I don't need that. But yes, okay, so antisocials are the ones who will kill you. Okay. Okay, so we talked about this one earlier. Look at this one. We're going to diagnose there quickly. Time frame. Looking at the time frame. 4 months. 4 months, it makes it schizophreniform. D, 4 months. 30 days to 3 days to 30 days. Remember, that is my brief psychotic. From 30 days to 60 days, right? 30 days to 60 days. I'm sorry, 30 days to 6 months is going to be schizophreniform. After 6 months, it becomes schizophrenia. Okay.
Well, that's my question. What would be schizoaffective?
Where were you when we discussed that?
Okay.
Oh!
I was like, where does
Go
it
back
fit
and
in?
watch the video. Schizoaffective is when you have, remember, I'm a teacher, okay? I do this all day. So schizoaffective disorder is when you have bipolar as well as schizophrenia at the same time. Okay.
It's
Yes.
that. Okay, thank you.
Schizophreniform. You're welcome. Schizophreniform. Yes, I'll do the time frames again. 3 days. And actually, I'm pretty sure I put in the top. I put a PowerPoint in there, I think, or some kind of slides. So, brief psychotic disorder, 3 days to 30 days. 30 days to 60 days is going, I'm sorry, 30 days to 6 months. So 1 month to 6 months, schizophreniform, a form of schizophrenia. Okay, schizophrenia or schizoaffective disorder is not diagnosed until 6 months. Okay, and this is a very typical question, right? It's been 4 months, so that's what we're looking at, the time frame in the question. Okay, so that's why it's important to know time frames when you're diagnosing. Look at this one. A 62-year-old woman, she presents for treatment 5 weeks after the death of her beloved cat. Prior to the incident, she worked full-time, enjoyed many hobbies. Since then, she stayed at home and isolated herself, stating she cries all the time. What initial diagnosis would you give her? Stop it. Stop it. Okay. So she does. She has major depressive disorder. She does. Okay. With generalized anxiety, there's a free floating anxiety. Free generalized anxiety, I'm looking for at least 6 months of having issues. Come here, Milan. Come here. 6 months of having issues, okay? So if it's been but it's free floating. I can't just point it to anything. Okay, it doesn't talk about whether or not somebody died or anything. It's you can't sleep, you can't do anything but it's 6 months of diagnosis. Acute stress disorder. Remember, that's the precursor to what? Acute distress disorder becomes on the 31st day. PTSD, bingo, PTSD. You got it, you got it. And persistent depressive disorder lasts how long? In children, it is 2 years in adults, 1 year in children.
Children is 1 year, adults is 2.
Bingo, bingo, bingo. You got it, you got it. Good, good. Look at this one. A 34-year-old man. He's got agoraphobia. Correct. Remember, my agoraphobics do not have to, they don't necessarily always have to stay home. You might see a question about a man who just goes to work and comes right back home. Okay, that can still be agoraphobia. They just don't like leaving their house. Okay, my agoraphobias, those remember under my phobic disorders, my phobias. So the treatment for those, we're going to go back to some behavior techniques. Remember, we're going to do flooding. Flooding is all in at the same time, right? If you're agoraphobic, we're just going to pull you out of your house. Or we're going to do implosion. Implosion therapy is imagine that you're leaving the house. Or you'll do systematic desensitization, and that's by Joseph Wolpe, remember? Okay, so that's how we treat those phobias. So whether it's a fear of leaving your house or a fear of spiders or heights or any of those things, that's what it is. That's how we treat it. Okay? These bigger guys. Okay. A 45-year-old is referred to a therapist. Look at that one. That is my histrionic. Yes. For the test, almost always my histrionics are going to be female and my narcissists are going to be men. Not that way in the real world, but for the test, again, they're not trying to see if you're the best diagnostician. We're just kind of see, do you know some basics here? Okay. So, and what I've said, if you've had me before, if you don't know the histrionic in your group, it might be you. Okay. She's the one that just likes lots and lots of attention. Let me show you a picture here. Let me show a picture that I pulled up. I don't see it today. So my histrionics, it's all about them, right? They really just want to make sure that you are aware that they're in the room. They're not as crazy. I'm sorry, they're not as indecisive as my borderlines. My histrionics really are not known for being promiscuous. Like my borderlines are in love with you every 5 minutes, right? But my histrionics really are not. Okay, so they're much more just flamboyant, full of life, lots and lots of attention. Okay, so here's one. This is my very attention seeking. Okay, so I always tell my women in the group, if you don't know who the one is in your girlfriend group, it's probably you. Okay, and again, not come to therapy. They don't have a problem. You got it. Those are my drama queens. Perfect. 35. There was a 35-year-old woman. Look at that one. Okay. So she's a psychiatrist for regular medication for major depressive disorder. The answer, Zyprexa? What is Zyprexa?
Antipsychotic.
Yeah. Is she psychotic? I hope you're
Oh,
not my doctor. Hope you're not my counselor. Give her some. Ooh, please. I'm not seeing any of you guys, just so you know. So she's not psychotic. So I'm going to give her some Zoloft. Now, Zoloft is an SSRI, and it's most, again, used for anxiety, but it's also used for depression. My Adderall, of course, is my stimulant that's used for my ADHD, and my Haldol and my Zyprexa are used as antipsychotics. Okay? Oh my goodness, I'm not coming to any of y'all. Be sure you sign in so once you're licensed, I can know not to go. I'm just joking. Anyone that I tutor definitely will pass the test and they will be fine. Okay. Let's look at this one. A college student. Look at that one. A college counselor. Where do you see he's going to kill him? Remember, antisocials are my sociopaths. Where do you see he's going to kill him? And I'm not your college roommate. It is not B. He is not antisocial. He is not going to kill him. Remember, those are my sociopaths. Okay. He's not a sociopath. Okay. Where do you see he's avoidant? Avoidant? People running out of choices. Answer's D. He's schizoid. Remember my schizoid? They just want to be by themselves. They
Oh.
just want to be by themselves. My
Okay.
the avoidance, it'll say something about not being judged. Okay. Their fear of judgment. He's lived the same place. He likes to be home alone. He doesn't really sees his family. On the weekends, he has no one. He tells his therapist he had the same roommate fresh since his freshman year, and he doesn't even know him. Okay? He is schizoid. I am sure you have a schizoid in your neighborhood. That is a house that you know not to go by. Don't ask him to buy Girl Scout cookies. Don't you dare sell the Halloween, go the trick or treating because he don't want to be bothered. Okay? Y'all know the schizoids in your neighborhood. You stay away from that. The weird house on the hill. Right? So those are my schizoids. Nobody, and they're happy with COVID. They're thrilled. Okay? Okay, with this one, which of the following evidence-based treatment modalities is most appropriate to treat a client diagnosed with borderline? We talked about that earlier. My borderlines use DBT. That's dialectic behavior therapy. That's where mindfulness comes from. That DBT. Okay. Here's the word I used before. The diagnostic category in which pathological behaviors are most likely to be egocentric. Those are my personality disorders. They are in sync with who they are. They are not coming for treatment. They are not. They are not. Okay, dokie. I'm going to give you one more. Let's look at this one. Okay. My 45-year-old man. Exactly. How do I know? How do you know that? What do you see? Bingo! He's limping. Exactly. Exactly. I'm going to rule out some medical stuff first, right? And unless your program include, a day of medical school and you can diagnose medical issues, 'cause my program did not. And I am a doctor, but I still can't see. I can't do that. And 15, your last one. A 15-year-old girl is brought to therapy by her stepmom, reports that the client obsessively pulls her hair and her eyebrows. What diagnosis is she most likely? Trichotillomania. You got it. You got it. You got it. One of my first clients when I started in therapy, she didn't have any eyebrows. And she came for treatment. I'm from South Florida, and she came for treatment because she was going scuba diving with her new boyfriend, and she was terrified he'd find out. So instead of actually getting treatment, she just had them like permanently, put in. So that worked out just fine. So I did treat her for anxiety as well, but we wouldn't have had enough time for them eyebrows to grow back in between now and the diving. Okay, I will remind you, if you are tutoring with me next weekend, there will be no classes whatsoever. I'll be celebrating my 55th birthday. I know. So, no groups, no individual tutoring, no nothing. I work
Okay,
9
so
hours a day, 7 days a week, so I get 2 whole days off.
we meet Thursday, no Thursday.
I said the weekend, girl.
Wow.
Okay,
Happy
sorry.
birthday.
Thank you. I just said the weekend. I didn't say about a week or anything else. Don't be freaking out.
Bye, Pam.
And it's been on my Facebook for like 2 months that I'm taking the weekend off, so don't be freaking out, okay? Okie dokie, guys. Any questions? I'm gonna stop recording.